Good evening, everybody. Good evening to participants in India and across the globe. I can see some people who have logged in from UAE and Malaysia as well. Welcome, all of you. Wishing you all a Merry Christmas and a happy 2022. I'm sure with this new year, we'll finally see the exit of the pandemic and once for all from our lives, hopefully, and our lives will go back to normal once again. Welcome to the 11th edition of Healthcare Insights, powered by RedMed and hosted by LBN Tech Solutions and All Ladies League. I am Megalai Senthilkumar and I'll be the host for this evening. And I head a digital marketing company called LBN Tech Solutions. And today's topic is diabetes and the kidney, a sweet misery. Today, we are going to learn about the link between diabetes and kidney disease and why it is so important for kidney disease to be diagnosed in diabetics, and lots of more valuable insights. So stay tuned, all of you. Today's speaker is Dr. Padmanabhan, Senior Consultant Nephrologist and Transplant Physician, Department of Nephrology, NU Hospitals, Bangalore. Welcome, Doctor. We are so honored to have you here for Healthcare Insights for today's session. A little bit about Doctor. His areas of interest are critical care nephrology, preventive nephrology, hemodialysis, transplantation, nephrology. And I welcome the moderator for this session, Jay Srinivasan, founder and CEO, RedMed. Extending care by design is RedMed's tagline, and it outlines how they attempt to address challenges in healthcare by expanding it beyond its customary confines. So Jay Srinivasan is a well-known person in this webinar series. And over to you, Jay. Before I hand over a little bit of a note to all the participants, after the moderated session, you can type in all your questions in the chat box and it will be addressed one by one by the speaker. Over to you, Jay.
Thank you, Megu. Thank you for that kind introduction. It was, as usual, it was very good and short, and certainly appreciate it. Dr. Padmanabhan, a warm welcome to you. Today is Christmas Day, so a Merry Christmas to you. And hopefully the rest of the days of the year will be filled with happy holidays for all of us. Dr. Padmanabhan, it is a genuine pleasure for us to welcome you here today. You're the second person from NU Hospital who has addressed the audience here. We have been extremely happy to have doctors in the past. Not all of our visitors are doctors. Most of them are, but we have had a few sprinkling of others as well, nutritionists and so forth. But it's particularly important for us to have a person such as you today to talk to us, because not only of the ongoing pandemic, but the idea of chronic diseases, especially diabetes, which is a very complex disease, as we all know, and the kind of havoc it can cause to many parts of the body, many organs over several years if left undetected or untreated. So one of the things we certainly look forward to hear from you today is some ideas as to what diabetes really is. I think we could start with that very fundamental, if simplistic question: what is diabetes? Because much as we all think we know, I think a lot of people still probably are unaware that diabetes is not just sugar. It's a matter of how it goes about affecting various parts of the body in various people, and not all people are affected the same way, as you and I discussed the other day. What is it that people could do proactively to take care of themselves? So we could start with that very simple fundamental question: what is diabetes? And then move on from that. I understand that you would also like to start off with a presentation of your own, which is excellent, because that can very easily stage the ground for everybody. So over to you, Dr. Padmanabhan. Once again, welcome.
Thank you very much, Mrs. Megalai and Mr. Srinivasan. Pleasure is mine to be with you all in this series of webinars for the benefit of people. And special day, Merry Christmas and a Happy New Year to you all too. So today's topic will be on diabetes and how it affects the kidney. And that is the reason why I chose this word, the sweet misery. So diabetes is something that we hear day in and day out. I think at least one or two of everyone's family members will probably have diabetes, and that is the actual scenario today. Yes, to start with, diabetes means increased blood sugar in the body. So we diagnose diabetes by checking the blood sugar. So there are two ways of doing it. One is checking a random blood sugar. The other is checking a fasting sugar and 2 hours after breakfast or after a 75-gram glucose drink. So this is normally what we do. And today we have a third dimension, which is called as HbA1c or glycated hemoglobin, which tells us what is the average blood sugar in the blood over the last 120 days or 3 months. Over the last 90 days or 3 months. The first one, we call it as random sugar. So if anybody's sugar, when they check it at any point of time in the day, if it is over 200 milligrams per deciliter, then we have to label them as diabetics. The more precise way of doing it would be to measure all the three. The fasting blood sugar has to be over 126 milligrams per deciliter. The postprandial or 2 hours after breakfast or after a glucose drink. Normally we give a 75 gram of glucose mixed in water and ask them to have it before we check the sugar after 2 hours. And the 2 hour postprandial, that is what we call it as, should be less than 140 milligrams per deciliter. And the 3 month average, which I said as glycated hemoglobin or HbA1c, has to be less than 6.4%. So this is how we diagnose diabetes in people. Now with this basic thing, let us go and explore the link between diabetes and the kidney.
A quick question, Dr. Padmanabhan, if I may.
Please.
You had mentioned these 3 different forms of tests, fasting, postprandial, and glycated, and there are 3 different figures. Obviously, these numbers can vary across different populations, right? Not only demographically, meaning age and gender-wise, but as also racially. Indians or South Asians versus somebody from Europe or somebody from the US, for example, or the Japanese or Chinese, for example. Would it vary very much?
No, the blood sugar levels are uniform for all human beings.
Mm-hmm.
So, this is one of the instances where there is no differences in terms of race or sex or region.
And the importance given to those specific numbers in terms of what is the risk predisposition for the individual remains the same across people?
Across the globe for the human race.
Okay, thank you.
So let me share the screen and then we'll go and explore the link between diabetes and the kidney. Are you able to see my slides?
Yes.
So this is the place where I practice nephrology. And if you really look at it, 50% of my patients do have diabetes and kidney disease. So
the locality is very appropriately named.
So that is why I have a very special interest in diabetes, because to me that is the commonest cause of chronic kidney disease in my patients. I'll give you a couple of scenarios. This is something that we see day in and day out in our outpatient departments. So the first scenario is of a 55-year-old male who has been diabetic for the last 12 years. And his average HbA1c or glycated hemoglobin has been around 8.9%. He actually visited an ophthalmologist or an eye specialist for some blurred vision. And when he was evaluated there, they found that he has an effect of diabetes in his retina. And that is called as diabetic retinopathy. And subsequently, the doctor there asked him to check his urine and his blood. And they found that he had protein in his urine, and his serum creatinine, which normally has to be less than 1.3 milligrams per deciliter, was high, which means more than that. So he was then referred to us for evaluation and management of his kidney disease. So this is one scenario. And Narayana Nethralaya is just next door to us. So we see more of these kind of referrals. This is the second scenario. Again, a similar middle-aged male with 10 years of diabetes and high blood pressure, smoker and ethanol user. He had some sort of chest discomfort on climbing stairs, and hence he consulted his heart specialist, and he was subjected to a lot of tests, including a treadmill test, which we are all aware of, and it was positive. And the cardiologist said it is better that he undergoes an angiogram. So we are all familiar with the word coronary angiogram, which is done to look at blocks in the blood vessels supplying the heart. Now, as a routine, anybody who is subjected to an angiogram undergoes certain tests, which includes a creatinine level estimation in the blood. And when they looked at it, it was 3 milligrams per deciliter. And the cardiologist said, we cannot do an angiogram as of now because the dye is harmful to the kidneys. So first meet a nephrologist. Let us see how we can sort this out before embarking in an angiogram. So this is scenario 2. This is the third scenario. So a 45-year-old female with 8 years of diabetes and a HbA1c of 9%, consulted her regular physician for swelling of both legs of 2 months duration. And then the physician checked her urine and it showed 3+ protein. I think all of us are familiar with how an urine report looks like, and 3+ protein or albumin was there. And subsequently, she was referred to a nephrologist for further evaluation as to why she has protein leak in the urine. Last but not the least, another 40 years old female with 7 years of diabetes had very frequent urinary infections in the last 1 year. Her diabetes control has always been poor. She had very high fever, pain in the loin with vomiting and a little blood-stained urine. And she was admitted to a hospital where she was detected to have a severe urinary tract infection with kidney failure. Her blood pressure was very low, and hence she was admitted to the ICU. She was given antibiotics appropriately, and then she needed a few sessions of dialysis. And because there was some blockage in her urinary passage, a stent was put in to clear the passage. She got better. She got discharged with good health, but she has a persisting mild kidney disease, which she never knew earlier. Now, these are some things that we see day in and day out in our practice. And what is common to all these 4 scenarios is that all of them have diabetes for a reasonable period of time. The diabetes control has been poor. If you look at it, it has been around 8, 9 hemoglobin A1c or glycated hemoglobin. and none of them had screening for kidney disease earlier. They were identified to have kidney disease when they went in for a totally different issue to a doctor. They never had symptoms to suggest kidney damage, and that would probably be the reason as to why they were not checked earlier. And as I said, kidney damage was detected while they were being tested for another complication. So basically, we call this as chronic kidney disease or CKD, which is very commonly known. It is a silent disease. It is progressive. It is irreversible. It does not have any treatment as of now. The best as nephrologists or physicians we can do is to try and slow the rate of progression. And the disease progresses over 5 stages, and it ends up in a stage where somebody needs dialysis and or kidney transplantation because the kidneys are no longer able to support their bodily function. So this is something that we commonly see, and the sad thing is that we do not have a treatment as of now.
Dr. Padmanabhan, if I may interject here for a moment.
Anytime.
You mentioned 5 stages. Could you tell us what those 5 stages are?
We classify chronic kidney disease based on the GFR or glomerular filtration rate. When you look at the kidneys are made up of millions of filtering units, 1 million each in each of the kidneys. And these filtering units are called as nephrons. And that is why the study of kidney disease is called as nephrology, because it's nothing but study of nephrons. Now, what does this kidney does? Through each of the nephrons, the blood is filtered. So by blood, I mean whatever is not necessary for the body is filtered at each of the glomerulus, and then it is excreted as urine. So whatever is not needed for the body is excreted as the urine, and what is necessary for the body is claimed back by the tubules. So the glomerulus is just a filter. So it does not know what it needs, what it does not need. So the moment the blood passes through that, it's a maze of small blood vessels. So it just gets filtered by the pressure difference. And what happens is these glomerulus are in continuation with tubular structure, which is called as the tubule. And these tubules know what is needed for the body and what is not needed. So it claims back from the filtered portion of the blood, we call it as filtrate. It claims back what is needed for the body, and finally it sends out what is not necessary or the waste as urine. So when we measure the function of the kidney, we measure the filtration rate or the rate at which the blood is filtered through each of these nephrons. And it is very difficult for us to measure real time. And so there are lots of mathematical formulae to calculate the filtration rate approximately based on the creatinine value, the race, the age, the body weight. There are numerous formulae, but most often we use 2 types of formulae. One is called as the MDRD and the other is called as CKD EPI formulae. And that gives us what is called as an estimated GFR or eGFR. Now we classify chronic kidney disease based on the GFR. So normally we have about 120 mils per minute. That will be the GFR. I'm telling approximately. There will always be a range anywhere between 100 to 130, 135. But we'll take an average. So 120 is what we call it as a normal GFR. And we classify kidney disease into various stages depending upon the decline in the GFR. So we classify 90 to 120 as stage 1, 60 to 90 as stage 2, 30 to 59 as stage 3, 15 to 30 as stage 4, and less than 15 as stage 5. And in stage 5, we have another subdivision called as stage 5D, where if somebody needs dialysis, then we call them as stage 5D. I have a separate diagram which I will show it as the discussion progresses.
Okay, thank you.
So basically, we are dealing with a very silent disease, a very progressive disease, a disease which does not have any treatment, a disease which cannot be reversed at all. And the only option that we have is to either continue on dialysis for life when that need comes, or undergo a kidney transplant, both of which are only treatments. They are not cure. So that is something that we have to understand. Now, let us look at the burden of chronic kidney disease across the world. I am only looking at adults, and most of the times I'm looking at elderly because the disease is more prevalent as we age. So if we look at the ages 65 to 74, you have 1 in 5 men and 1 in 4 women having chronic kidney disease across the world. And when it crosses 75 plus, you have at least 2 in 5 women or men having chronic kidney disease. So it's a very big epidemic proportions. Now, when we look at the causes of chronic kidney disease, what stands out here is that a majority of it, almost 40% of it, is because of diabetes. And we have another 25% of it with blood pressure. So when we combine diabetes and high blood pressure, they account for more than 2/3 of cause of chronic kidney disease. And that is why we say that diabetes and high blood pressure are probably the most important things that we need to address and keep under control. The next question that arises to us is that should everyone undergo a test to see whether somebody has some form of kidney disease or not? So this is what is called as screening for a chronic disease. So screening in general can be of 2 types. One is a population-based screening. You screen every individual for the presence or absence of a particular chronic kidney disease. Or you have what is called as a targeted screening, where you identify people who are at risk for developing that particular disease and then target your screening towards them. So diseases like diabetes, they would probably need a population-based screening, while diseases like chronic kidney disease will have to have a targeted screening to be cost effective for the government. So in order to do a targeted screening, we should know who are the people who are at risk of developing chronic kidney disease, and then we can apply the screening tests to identify these diseases in those people. So when we take chronic kidney disease, look at it, diabetes, as I said, that diabetes and high blood pressure are the most common cause, or 2/3 of chronic kidney disease are because of these 2 conditions. So obviously they become risk factors for chronic kidney disease. Then the next major one is those with either a heart issue or a stroke. So this is again becoming more and more common with diabetes and hypertension. Obesity. Obesity, I think, is another topic on its own for discussion. And obesity today is very, very prevalent. In fact, today, if you look at Times of India, you have 3 types of hunger. One is the people who really do not have food. Then the other one is those who have micronutrient related problems. And the third one is those who have plenty and they end up becoming very obese, and then they develop a lot of disorders, which we call it as non-communicable diseases. And obesity is a risk factor for developing chronic kidney disease. And the next important thing is any of your close family members, if they have a history of chronic kidney disease, then the others are also at risk of chronic kidney disease, because we have seen chronic kidney disease clustering in families like that of diabetes. Tobacco use, especially the cigarette and BD, which we all smoke. And then elderly. So by elderly, I mean 60 plus. So again, as we age, these are all diseases of aging or longevity. So as we age, then our risk for chronic kidney disease increases. So in general, we need to target all these people and ask them to screen themselves for the presence of kidney disease. So the next logical question is, how do we screen them? So kidney disease screening is very, very simple. So we just do a urine examination for the presence of protein in it, and we check the blood for serum creatinine, and we can easily calculate. There are all these formula are available in the net. All we need is to input whatever requisites are there, and then it gives you your eGFR. So the tests are very simple. You have to do a urine examination for presence of albumin or protein, and you'll have to do a blood test to estimate the creatinine in the blood. And subsequently, you can use the MDRD or CKD EPI formula for calculating the estimated GFR. This is what I said. So the staging of chronic kidney disease. The stage 1 is glomerular filtration rate or GFR of more than 90. Then stage 2 is 60 to 89. Then stage 3, nephrologists classify it as A and B, but in essence it is 30 to 59 is class 3. And then class 4, as I said, is 15 to 30, and less than 15 is kidney failure. And if somebody is on dialysis, we call it as stage 5D. There are much more complex ways of staging using both the GFR and the amount of protein leak in the urine, but I think that is more of an academic interest rather than for a regular staging, which is more common this way. Now, I will change gears here, and I will go into diabetes as such. Now, insulin was discovered in 1921 in University of Toronto, and these are the two gentlemen. Banting was a student, and Best was his teacher, and they extracted insulin from the pancreas, and this is the dog which received the first shot of insulin. I think this was a game changer in terms of management of diabetes. But then the question that I always ask is that the scenario changed. Death from disease to death from complications. So people started living long with diabetes, and as a result, we are seeing death because of complications of diabetes. Diabetes affects various organs of the body, and these organ damages are causing a lot of mortality in our population. So when you look at it, heart disease and stroke causes 65% of deaths in diabetics. Diabetes is the leading cause of blindness in the adult population. It is the leading cause of end-stage renal disease. I said about 40% of people who are on dialysis, they are there because they have a diabetic damage to the kidneys. It accounts for over 60% of leg amputations because of the blood supply being compromised to the leg. The dental disease is also very common. 1/3 of diabetics have some form of the gum disorders. We call it as periodontal disease. a lot of problems like birth defects, abortions, and excessively large babies when it comes to pregnancy and delivery, then most of them are susceptible to life-threatening acute complications. It can be a very low blood sugar, it can be a very high blood sugar, or it can be excessive ketones in the body, or it can be a very severe infection because of diabetes, or it can be an acute heart attack or an acute stroke. And the outcome is worse when it is associated with any other form of disease. So when you have diabetes plus any other disease, then the outcome is going to be very bad. So as I said, we should know where we are standing in terms of numbers of diabetics. So this is in 2015, we have about 415 million in the world suffering from diabetes. And the projected figures in 2040 is almost 642 million. And this is the data from the International Diabetes Federation. And India is not far behind. We have about 77 million people with diabetes. This was as on 2015. And the expected numbers is about 134 in 2045. Now, when we compare the amount of diabetics that we give to the world, 1 in 6 diabetics in the world are from India. So India is going to be a capital of diabetes very soon. China is there, but I think India is going to overtake China soon. So it is very, very common. It is not type 1. In the Western world, type 1 diabetes is very common. In India, it is type 2 diabetes that is more common. So to be precise, type 1 diabetes occurs in very young children, and that is because of lack of insulin in the body. So they will be on insulin from day 1. Whereas type 2 diabetes occurs in adults, and it is because there is resistance to the action of insulin in the tissue. So that is the reason for type 2 diabetes, and India is poised to become the capital of type 2 diabetes in the world soon.
Dr. Padmanabhan, if you can hold on to this map for just a few seconds.
Please.
Many years ago, when I was speaking to somebody, a diabetologist, he happened to mention that the numbers we see here in the form of the colored map is to some extent, it's to a great extent colored by the fact that Tamil Nadu has the oldest registry for diabetes in the country. It goes back some 50, 60 years. So there is a well-documented registry of the progression of diabetics in the country, whereas as you go further northwards, it's not very much so. So that's number one. The second thing I'm curious about is many of the mountainous regions seems to be at the lowest end. Is there any connection between the two, or I'm just looking at the pictures and hazarding a guess here?
See, it's a lifestyle disease. When we look at the southern parts of India, I take it as very well developed compared to the mountainous parts of India, the north and the northeastern parts of India. One, the lifestyle has significantly changed. We have become more sedentary type of work. Whereas in the mountainous areas, people still do a lot of physical activity. So that is number two. I am not very convinced about rice eating, because I'm sure there are rice is probably the staple diet in many places in our country, except the wheat basin. In all others, it is diabetes. Some of them tell that people in Kerala use a lot of tapioca, and that could be one of the reasons for high prevalence of diabetes in that part of the world, that part of the country. But to me, it probably reflects the more sedentary lifestyle in these parts of the country compared to the mountainous regions in the north and northeast. Any other questions, Mr. Jay?
No, thank you for that response.
So when we look at how is diabetes expanding worldwide, you look at this, the African subcontinent, the South American continent, and India, and parts of the Southeast Asia. I think these are the ones which are contributing to a significant amount of increase in diabetes worldwide. And I think this is true because of the improvement in probably economics, the change of lifestyle from a hard physical work to a more sedentary lifestyle. I do not know, but the sad fact is it is true that these Southeast Asia, India, Africa, and the South America is going to contribute to a significant proportion of diabetics in the world. So as I said initially, this is how we diagnose diabetes. So this is a more precise way of diagnosing. As I said, the fasting plasma glucose should be more than 126. The 2 hours has to be more than 200. And the 3-month average has to be 6.5 or more. But we have, what is interesting is this particular portion of the table where we have what is called as pre-diabetes, when the HbA1c is between 5.7 and 6.4. The fasting glucose is between 100 to 125, and the 2-hour glucose is between 140 to 199. And this is what we call it as pre-diabetes. And these are people who are potentially going to develop diabetes over the next few years or so. So this is probably the place where we need to catch them and give them a lifestyle modification so that they do not get into this particular phase, which is going to be very difficult to manage. And obviously anything that is less than this is called as normal. So again, diabetes has its own risk factors like any other form of chronic kidney disease, any chronic disease. So we generally classify the risk factors as modifiable risk factors on this side and non-modifiable risk factors on this side. Non-modifiable means that you are endowed by birth with that. So there is nothing that you can do to change that. So the genes, it comes to you, you have no control over it. The family history, again, that is something that you have no control over. The race and ethnicity, you do not have a control over it. Age, again, nothing much we can do about it. Then if somebody has diabetes during pregnancy, I think they are at a risk of developing diabetes in the future. And of course, use of certain medications, especially the steroid medications that are being used for various diseases, they tend to cause type 2 diabetes mellitus. Of course, we have a host of modifiable risk factors like obesity or overweight, physical inactivity, I said sedentary lifestyle, then poor eating habits, especially what we call it as the junk food, then high blood pressure and smoking. These are some of the modifiable risk factors. We can work on them especially when somebody is in the stage of pre-diabetes, as I said, or if somebody has a very strong family history, they need to work on all these things so that it prevents diabetes occurring in them at a later stage. So do we have any symptoms for type 2 diabetes? So normally what are we taught? These are common symptoms: excessive tiredness or fatigue, blurred vision, excessive thirst, a fruity breath, increased hunger, so they keep on eating, increased urination. So this three are called as the triad: increased urination, increased hunger, and excessive thirst. This is called as a triad of diabetes. So, but if somebody has any other vague symptoms also, it is worth checking for diabetes in all these people. So to me, type 2 diabetes often does not have any obvious symptoms. So most of it is identified when somebody goes and checks for a totally different reason. See, today we have a lot of pre-employment checkups happening. Then we have an annual health check in most of the companies and offices. And of course, if you have to take a life insurance policy over a certain age, they mandate the health check that needs to be done. So we have other ways in which we do it. Somebody gets admitted for a surgery and then they do a test and then they find that somebody has diabetes. So most of the times it is identified casually, where we go in for testing for a totally different reason. Very few people have all these symptoms to tell us that, look, go and check for diabetes. Now, the next question is, what are the symptoms of kidney disease in diabetics? Because this is our topic of interest. Now, it is silent most of the time, so we do not have any symptoms. And this is true of any form of chronic kidney disease, because by the time symptoms occur in chronic kidney disease, it is too late in the stage of disease and most of them will require dialysis very soon. But of course, we have a lot of symptoms like protein in the urine, which has accidentally checked, swelling of feet, like a patient whom I had spoken at the beginning of this, then an increased need to urinate. But what is more important for me is that a reduced need for insulin or diabetes medication. See, most of the times somebody comes and tells me that my sugar has always been 300, 350, and all in a sudden in the last few months it has become very normal, and occasionally my sugars are going low also. And I have brought down my list of medications from 3, 4 to 1. But to me, it rings a bell. Does this person has this person developed kidney disease? Because the moment somebody's kidney disease sets in, one of the things that happens is the reduction in the need for insulin or diabetic medications. And as the disease advances, many of them will get recurrent episodes of low sugar. So one of the things that I ask most of my patients is, do you have recurrent episodes of low sugars, or has your diabetes suddenly become very well under control? So these are two questions that I do not forget to ask all patients who come to me in my OPD clinic.
Doctor, this is very interesting. It's counterintuitive, because for people who have been following their sugar levels, maybe because they are pre-diabetic or because they come from a family of diabetics, if they start to see it go down or under some kind of control, they should not rest easy, but to pursue it to its logical conclusion to negate the possibility of something like this. Correct?
Yes, I'm not saying that this heralds kidney disease. It can herald a liver disease. See, liver disease also causes low sugar. Okay, and it can herald a severe infection. So sometimes when the infection is very severe, the sugars tend to go low. So, I mean, these are things that I normally watch for. If somebody's sugar has been by and large not very well controlled, and all in a sudden for no reason it gets very good and they feel very happy, then I always tell them that please check your urine for protein and your blood for serum creatinine before you feel really happy with that. Of course, there are certain people who will do a lot of adherence to the diet and medications, and there it can happen. But a word of caution, especially in somebody who has been having a very difficult time in controlling the sugars, and suddenly for no reason it gets very well under control or goes low, then beware of kidney disease. This is something that I normally tell people.
So so if for no reason they have had a lowered sugar level, and you ask them to go and check for kidney related proteins and so forth, and if it does come back, if the tests come back to show that it is what you hypothesized was indeed correct, at that point, is the person irreversible, in an irreversible condition, or can they still do something to go back?
See, the moment the creatinine goes up, the disease becomes irreversible. See, when I look at like chronic kidney disease, the diabetic kidney disease also has a staging. See, early in the stages, because of high sugars, the filtration increases. So we call it as a stage of hyperfiltration, where your GFR is actually more. That is stage 1. Then we have a stage wherein, in view of a continued high filtration, what happens is protein starts leaking intermittently in the urine, and we call it as microalbumin, because our routine tests for urine protein or urine albumin cannot detect it. The quantity is very less. So we have to have a separate means of detecting this. We call it as microalbumin. And then you have a stage of the disease where this microalbuminuria is intermittent. So it is up to this particular point that it can be reversed with good control. The next stage is persistent protein in the urine. And then it goes into a massive protein leak and a decline in GFR. So we can only control or reverse the disease in a stage where the microalbuminuria is intermittent. You don't get it always. You get it at sometimes, you do not get it. So that is the reason why we ask people to check for the involvement of kidney in diabetes in an annual basis. So I'll look at I'll discuss the screening as we go through this talk, because that is very, very important. In the very early stages, we still can reverse the diabetic effect on the kidney, but beyond a particular point, it is not reversible. We can only try and slow the progression. So diabetes can affect the heart, the brain, the peripheral nerves, the kidneys, the blood vessels in the legs and the arms, the eyes, where it can form glaucoma or a high intraocular pressure, cataracts, and as I said, it can affect the retina, and it can cause gangrene, where the blood supply to the fingers and toes are compromised. So this is what I was telling Mr. Srinivasan, that this is how the diabetic kidney disease progresses. You have normal albumin excretion, and then you have a stage of microalbuminuria, which is intermittent. Then you have a stage of persistent microalbuminuria, and then you have overt protein leak in the urine, and then there is a decline in the GFR, and it ends up with kidney failure. And when we look at parallelly the blood pressure and the risk for heart disease or stroke, it increases. So invariably, people who have protein leak in the urine do have blood pressure, and they have probably the highest risk for heart disease. So that is why we'll have to identify somebody at this particular point where there is intermittent microalbuminuria. This can be reversed. If you see the picture here, you can reverse this. Whereas the moment it crosses this and this, the chances of reversal is not there. So next, we go to the bottom line. Diabetes is increased blood sugar. So it is that increase in blood sugar which causes damage to all the organs of the body. So if we control the blood sugar appropriately, then we can reduce the risk of organ damage because of diabetes. So here, I'm just quoting one study. There are innumerable studies. For every 1% drop in A1C, A1C is glycated hemoglobin or HbA1c, you have a 21% decrease in any of the diabetes related end organ damage. You have a 14% risk reduction of developing a heart attack. You have a 12% decreased risk reduction in stroke, and a 37% decrease in risk for developing microvascular disease. Microvascular disease means kidney disease, eye disease. These are two major microvascular disorders. For all of us, these are two landmark studies which told us that if you control your sugars very well, then your risk of end organ damage and death comes down significantly. One. And not only it is during that period of the tight blood sugar control, but it also has a legacy effect. So it goes down for years together. So the body remembers. So this is called as metabolic memory, and this is very common. And that is why we always insist people to control sugars as much as possible, the initial stages, so that the metabolic memory remains there in the body for a long time. Now, the next question is, when do we look at screening for complications? And the answer is from the time of diagnosis. There is a slight difference between the type 1 diabetes and type 2 diabetes here. In type 1 diabetes, we have a time frame. So we don't check for organ damage as soon as we detect the type 1 diabetes, but we look at it after 4 or 5 years of type 1 diabetes. And in some people up to 10 years for certain organs. Whereas in type 2 diabetes, the diabetes itself is identified many years after the real point of time when the sugars went up the normal range, above the normal range. So we can have people with an organ damage at the time of diagnosing diabetes also. So this is something that we have seen. Many a times they go to an eye doctor, they find that there is a damage of diabetes in the retina. Then they check for sugars and the sugars are found to be high. So we have to start checking for complications from the time of diagnosis. So how do we screen? We screen for the nerve damage annually. We do a foot examination for sensations. We look for ulcers. We look for the blood supply, etc. This is done annually. They are very, very simple. For the eye disease or retinopathy, you have to have an eye examination. So you dilate the fundus and look at it. Or today, fundus photography is available in most places. So this needs to be done annually. And for the kidneys, diabetic nephropathy, we do a urine analysis and then subsequently a serum creatinine, and this also needs to be done annually. Then we do not recommend screening for heart attacks or strokes, because if there are no symptoms, then there is no way in which we can identify it. However, we look for blood supply to the foot and in the hands. So we do an examination of the pulses in the legs. And then if there are symptoms, the symptom of peripheral vascular disease, we call it as claudication. Claudication means as somebody walks, they have pain in their legs. And that is because the blood supply cannot increase. The blood vessel is, the lumen is fixed because of the loss of elasticity. So as we walk or as we do exercise, our blood circulation to the legs have to increase. If it does not increase, then there will be pain. And if somebody has pain on walking, and then they'll have to stop walking because the pain is severe, then after a couple of minutes, the pain is relieved and then they continue walking. This is called as claudication pain. And if somebody has claudication pain, we'll have to look at ankle brachial index and see whether anything can be done. So these are common things that we normally screen for people with diabetes. Let us stop here and maybe we can have some discussions and then proceed further. Mr. Jay. Are you able to hear me?
Jay, you're muted. Jay, you're muted, so you need to unmute. Yeah. Thank you.
Sorry about that. Can you hear me now?
Yeah. So I think we will take a break here. Let us discuss some, sort of a question answer session. If you have something to take it forward. And then I have a couple of more slides, which I will do it as we go.
Okay. So, Doctor, I have a couple questions relating to your presentation. It was a wonderful presentation, very informative and not just useful, but very easy to understand as well. So thank you. On behalf of everyone, I would like to thank you about that. My first question is, in an earlier slide, you mentioned that CKD, one of the fundamental causes is diabetes, sugar levels, and the other one was hypertension. So on this table that we are seeing here, when you talk of coronary artery disease, isn't hypertension a future predictor of CAD? Number
Yes.
one. And number two, if that is so, the existence or progression of hypertension is something very easy that all of us can perform, right? Just by doing a BP test often enough and keeping a logbook of what the numbers were and whether they were rising. Isn't that so?
Yes. No, in fact, it is a common practice that anybody who has diabetes will have to have their blood pressure examined because they're basically twins. They go together.
Okay.
And the risk factors for heart disease and stroke is common, both diabetes and high blood pressure. And the same is true for kidneys.
Okay. So this is something that every ordinary person beyond a certain age can do in their home.
Yes.
Quite often. One doesn't have to go for a lab test. So that's my first question. The second question, and we'll come back to a set of questions that you and I discussed, and then open the floor to the audience. My second question relating to your presentation, you talked of protein leak, that of protein seen in the urine. Now, this protein escaping from the body is seen as a major problem as far as kidney disease is concerned, correct?
Yes.
So my question on the reverse, the proteins being in the body, does that contribute to good health in some form, these proteins that are escaping? And my second question as a part of that, because you had said these conditions are irreversible, is a protein therapy of some sort in the future a possible thing to rectify that leakage?
So I'll take the first question. When I said that the kidney filters substances out of the blood into the urinary space, proteins cannot cross this particular barrier. So we call it as the glomerular filtration barrier. Proteins are actually necessary for the body, and that is what is actually there in the blood. And so these cannot escape out of the system. And so if they do escape out of the system, then that indicates that there has been a damage to the glomerular filtration barrier, which is nothing but a kidney disease.
So it's not as if the protein itself is required to rectify the kidney.
No.
Okay.
So protein is a marker of damage to the intactness of the kidney or the filtration barrier.
Got it.
Number two is when the kidney is damaged, it is leaking proteins into the urinary space. Now, when we give more proteins, then more proteins will leak because the kidneys cannot, or the blood, the body cannot hold the proteins. The blood has to go through the kidneys and then only come back. So the more proteins you give, the more proteins will leak into the urine. And leakage of proteins itself can worsen kidney disease. So we call it as progression of kidney disease. For progression of kidney disease, one of the things is protein leak. So in all types of kidney disease, we try to contain or reduce the protein as much as possible. So giving extra proteins is going to cause more damage than the other way around.
Okay. Thank you, doctor. I'm quickly running my eyes through the document that you and I shared, the Q&As. Many of them you have already answered to very good detail in your presentation. So I'm going to skip many of them unless they are asked and you may want to repeat yourself. So let me jump down to a couple questions perhaps that have not been discussed yet. So there is a question here, can kidney damage from diabetes heal? And basically your answer was that CKD, if it has been diagnosed, is an irreversible condition, correct? Any specific diet diabetics with kidney disease have to follow?
Yeah, see, diet in kidney disease is very common, whether it is a kidney disease related to diabetes or whether a kidney disease is related to high blood pressure or various other causes that result in chronic kidney disease. So what we normally do is most of them, 95% of them have high blood pressure. So we tell them to restrict the salt intake, which is very good for high blood pressure. Number two, we tell them to have a restriction on fluid intake, especially when somebody has swelling of legs or face and the urine output is not very good. Then we ask them to restrict their fluid intake too. So it will depend upon the amount of swelling. When I examine them, I decide whether they need a fluid restriction or not. The third thing, as I said, that we always restrict proteins in their diet. So we give about 0.6 to 0.8 grams per kilogram of body weight. Normally, we take about 1 gram per kilogram of body weight in terms of protein. So we have to restrict the proteins in the food in patients with chronic kidney disease. Then the fourth major thing that we normally restrict is foods that are rich in potassium. So when the kidneys do not function optimally, potassium tends to get retained in the body, and potassium in the blood is not very good for the heart and all the other tissues. So we tend to restrict foods which are rich in potassium. When you look at foods which are rich in potassium, you have fruits, you have fruit juices, you have dried fruits, bottled drinks, coconut water, ragi. So these are some of the common foods which are very rich in potassium. So normally we allow certain amount of potassium because it is necessary. So we allow one fresh fruit a day, which is roughly equal to a small elaki banana or half an apple, and that is what we normally tell people to take. The last one is the calories. So we normally restrict the calorie intake to about 30 to 35 kilocalories per kilogram body weight. And if somebody has diabetes, all the restrictions for diabetes will remain in place, which means they're not supposed to take a lot of refined sugars. Then sweets is a no-no for them on a daily basis. Occasionally is fine for me. Of course, fried items, all those things we tell them to restrict. So this is roughly what we tell people to follow in terms of diet in chronic kidney disease, and that is the same for diabetic chronic kidney disease also.
Okay. Doctor, you mentioned fluid intake in your response just now. So why is frequent urination a sign of diabetes?
See, there is something called as osmotic diuresis. Okay, osmosis we all know. Mm-hmm. When a substance which is highly osmotic passes through a tube, it attracts water. You follow me? So when somebody has very high sugars, then the sugars get filtered through the kidneys into the urine, because the kidneys can only hold blood sugar to a certain level.
And your voice is breaking.
Yeah, the kidneys can hold blood sugar only to a certain extent, and beyond that it leaks into the urine. So normally anything that is above 180 milligrams of blood sugar, then you have sugar leaking into the urine. And glucose is osmotically active, so it prevents the fluid from getting reclaimed by the tubules. So you have a lot of urine coming out.
I see. Okay. Prolonged use of insulin damage the kidney?
No.
Okay.
Most of the drugs are for treating diabetes are safe even in kidney disease. There are only certain medications that we tend to avoid, but insulin is pretty safe.
Okay. So we have been talking of kidneys thus far. Do kidney stones that most of us are familiar with have any bearing on this?
No, there is no link between diabetes and kidney stones. No.
Okay. Okay. So a diagnosis of kidney stones has nothing at all to do with diabetes per se.
Yes. Yes.
Okay. What's the difference between blood sugar and urine sugar?
I mean, it's self-explanatory. When we check for sugar, blood, you call it as blood sugar. When we check for urine in the sugar in the urine, we call it as urine sugar. Mm-hmm. So normally, sugar is not filtered, or whatever is filtered is reclaimed by the kidneys. So we do not get sugar in the urine.
Okay.
So if we get sugar in the urine, then it means that your blood sugar is high. Of course, there is a very peculiar disease We call it as renal glycosuria, but I think that is beyond the scope of discussion here.
Doctor, you have dwelt for quite a significant time today on the issue of diabetes affecting various organs. In a similar fashion, kidney disease, does it have the capability to spread elsewhere, as in the case of cancer?
No, kidney disease does not spread. But we'll have to understand that there will be an effect of kidney disease in almost every organ of the body. See, basically the kidneys excrete what is not necessary for the body. So it basically does a major scavenger work. So it is like when your drains are clogged, you get a lot of back pressure effects. So it does affect the bone marrow, it affects the heart, it affects the blood vessels. So you have an effect of a reduced kidney function on all the other organs of the body, but it does not spread.
Okay.
Not like cancer.
Okay. One final question from my side, Doctor, before we open up to the audience. There's a question here about gout. Is gout a sign of kidney malfunction of any sort?
No, actually, I would look at it in a slightly different way. Uric acid is normally excreted by the kidney. So gout is nothing but high uric acid, which is getting deposited in the joints, causing inflammation and swelling. We call it as arthritis, and typical uric acid related arthritis is called as gout. So uric acid is normally excreted through the kidneys. So when somebody has chronic kidney disease, we expect the uric acid level in the blood to be high. But people with chronic kidney disease do not get gout just because they have chronic kidney disease. So if somebody with chronic kidney disease do come to me with gout, then probably I have to look at certain other things. One of the common things that we see is lead poisoning. Lead causes gout, and if somebody has chronic kidney disease and develop gout, then I always look at whether there has been some amount of lead poisoning. On the other hand, people with gout can develop chronic kidney disease because the same uric acid which gets deposited in the joints can get deposited in the kidneys also and cause kidney damage. Or because of arthritis, they tend to take a lot of painkillers, and these painkillers can in turn affect the kidney.
I see. Okay. So when you talk of lead poisoning, we are looking at paint and things like that.
Yes.
Okay. All right. Thank you so much, Doctor, for these are the questions I had. What we could do now, Megu, perhaps we could open up to the audience at large if they have any questions, and the doctor could order.
There are lots of questions here. Doctor, we can close the share screen now. Or yeah. Thank you. So we have a few questions here. I will start from Mr. Prem Kumar. How to avoid or delay chronic kidney disease? I think you've already detailed explanation for diabetes. So this applies for chronic kidney disease also. Yeah, okay. And Mr. Ravichandran says EGFR, simple way to calculate. I think he wants the formula, the calculation. Mr. Ravichandran, you want to ask the question yourself? You can unmute and ask. And he also wants. Yeah.
Can you give a very simple formula how to calculate from creatine values?
See, these are very complex mathematical calculation.
Yes.
And maybe if you ask me after all the formula, I will not be able to tell. Almost if you go to the internet, you can download EGFR calculator. You will have all these things, and you just have to input your creatinine value, then they will ask you age, and then what is your body weight, what is your sex, are you black or non-black. So these are few things which are commonly asked. You just have to enter these values and then click, you get your EGFR. It is freely available in the net. These are almost 3-4 line formula which are impossible to remember. I don't bother to do that.
Okay, sir. Okay, sir. Thank you, sir.
We were
Sir,
students.
my next question is, elevated urea, is it connected with diabetes?
No, see, elevated urea, I would not give too much of importance to it because there are lots of things that can cause urea to go high. See, if you're dehydrated, then urea goes high. If you're having some steroid medications, then urea goes high. Some medications like doxycycline or tetracycline medications, they cause urea to go high. If there is some amount of bleeding inside your intestines, then urea tends to go high. So urea is not a sign of diabetes or not an accompaniment of diabetes. Urea, yes, it increases in people with kidney disease. But again, I will not use urea as a marker for any calculation. I will use creatinine because the variations are very, very less compared to urea.
Yes, sir. Sir, this creatine value, does smoking and drinking have an impact on it?
See, smoking directly affects the kidney. And when kidney disease progresses, creatinine automatically increases. So it is not that smoking causes a rise or fall in creatinine. Smoking is harmful to the kidneys, and as a result of which creatinine goes up.
Yes, sir. Sir, this new generation of medicines which are being used to filtrate out the excess urine through excess sugar through the urine, what are the comments, and is it advisable to use it on long term? As a nephrologist, what is your opinion, sir?
See, they are very good medications. One. Number two is I would be very cautious about using these medications without the regular checkups with your diabetic specialist. And there are effects, as I said, that these also can cause some amount of kidney damage themselves. Though these are very, very rare, we see only an occasional patient with this. But overall, they are very good medications.
Thanks, sir. Thanks, sir. Thanks for your inputs.
Thank you. Thank you, Mr. Ravichandran. We move on to the next question. There's something about pre-diabetics. So other than the values of HbA1c and the glucose tolerance test and postprandial blood sugar, what are the symptoms of a pre-diabetic has to look for, doctor, from Sandhya?
Don't have any symptoms at all.
Okay.
So these are all identified only by testing.
I see. So periodic checking is important.
Yeah.
Then, Mr. Prem Kumar, what are the controllable factors to avoid or delay CKD? I think this was mentioned in your presentation. Anything you want to add, Doctor? Here? Controllable factors.
See, basically, to me, if somebody is a diabetic, the blood sugar has to be controlled. By blood sugar control, I mean a fasting sugar of around 100, a postprandial sugar of around 140, and HbA1c of less than 7. That is one. Number two is a good blood pressure control if somebody has high blood pressure, and that will be less than 140/90. Then to quit smoking if somebody is smoking, to quit alcohol if somebody is taking excess alcohol. If somebody has high cholesterol, I think we'll have to take medicines to keep the cholesterol under control. We'll have to maintain a very healthy body weight, which means we'll have to be active physically and ensure that the body weight is in the reasonable range, not in the overweight or obese range. Then avoid over-the-counter medications, especially painkillers. Then keep yourself well hydrated. So you also need in fact, one of the reasons for rapid progression is dehydration. So keep yourself well hydrated. I think these things should reduce the progress. Never miss an appointment.
True. Thank you. That was very comprehensive. Mr. Muruganandam asked, what is the effect of sarcoidosis? I hope I'm pronouncing it right, on kidney. Can the effect be reversed?
Yeah, this is one of the conditions where we can reverse the effect on the kidneys. So most of the times when we see sarcoidosis, it is a very high calcium in the blood that actually causes damage to the kidneys. Though we have seen the same sarcoid nodules occurring in the kidneys also. So here we use steroid medications, and once the calcium comes under control, automatically the kidney function gets reversed. So it's one of the things that we actually feel very glad to treat.
Okay.
Megu, one Dr. Arilvi has been raising her arms. So could you?
Yeah, I think we can. Dr. Eril, you can unmute and ask your question. Dr. Eril is a pathologist from Bilroth Hospitals, regular to our healthcare insights. Welcome, Dr. Eril. Please go ahead.
Sir, I just wanted only two questions, as you have already mentioned about the brittle diabetes. That is a very low sugar, and that occurs in type 1, isn't it? You mentioned. But one of my niece, she has developed it after the age of 50. But the ancestor, that is the close relative, her father was a diabetes. But now she is not able to control herself. The hypoglycemic index is very low in the early mornings. That has become little precarious, one thing. Another question for me is the hypertensive, antihypertensive drugs. In your experience, the amlodipine, telmisartan, or metasartan, is it injurious to develop CKD in a long run, long use? That is the two questions I have to ask you.
The brittleness of diabetes in type 2, we do not call it as brittle diabetes, but we do have people for whom it is very, very difficult to control. And the problem is not of high sugars, the problem is of low sugars. So to find the right dose of medication in them is a challenge. And this is probably a very, very small group of people. And the only thing that will be helping us is to keep checking the sugars very frequently. And especially in the nights, and I'm more worried about low sugars in the nights, which may be actually dangerous. So in such a situation, I wouldn't mind a slightly high sugar rather than a low sugar, but there is no shortcut to it other than checking sugars more frequently and titrating the dosage of medications. As far as blood pressure medications are concerned, they are actually good. So control of blood pressure is probably the key. Irrespective of whatever medication you use, the key is to get the blood pressure under control. And all these medications have been in use for decades now, and none of them has been associated with causation of chronic kidney disease. Yes, when somebody has established chronic kidney disease, there are certain medications that we use very carefully or avoid, especially telmisartan, the ACE and ARB group of drugs, but they themselves are not toxic to the kidneys.
Thank you.
Thank you very much for your wonderful answers. And I am on all these medicines, the hypertensive drugs for so many years, but I am under control. But the diabetic people, as you said, I've told the same thing. And one more thing, that insulin which is available, that is the one new latest preparation of the insulin. Can we advise for her that micro insulin or some other labeled one?
My direct treating of diabetes is very minimal. I treat only people with chronic kidney disease, where my requirement of insulin use will be significantly less. I think you should look at endocrinologist using it regularly, so that they guide you regarding the dosage and the monitoring and how to modify. That will be probably a more apt way of.
Thank you very much, sir. Thank you.
Thank you, Dr. Moving on to the questions, Mr. Prem Kumar has asked, I believe kidney controls blood pressure. How CKD affects BP?
See, almost 95% of people with chronic kidney disease have hypertension. And that tells us that kidney plays an important role in control of blood pressure.
Yeah. Next question. You mentioned pain in the legs during walking. Any particular part? Is it feet, the calves, or the thighs?
Usually the calf muscles pain.
Okay.
So that is very typical of claudication pain.
Okay. That is while walking, doctor, or while at rest also? While walking?
While walking, and it just within a couple of minutes, it subsides if you rest.
I see. Okay. Mr. Muruganandam has asked us, serum creatinine level maintaining around 1.4 on sustained basis, neither goes up nor comes down. Does it indicate CKD? 1.4.
See, technically it indicates chronic kidney disease. Now, when we look at kidney disease, there are lots of areas where we do not have full knowledge. Now, there are a group of people who still come to me. They're with me for almost 15, 16 years, and their creatinine has not crossed 1.5. Okay. Now, I do not know whether to call it as pathological. If it is pathological, it has to progress over time. It has not progressed. Or whether it is a variation. See, how did we achieve that 1.3 as the upper limit of normal? That is because majority of them. So when we do statistics, we have what is called as a bell-shaped curve, and we take a median as the normal. So we have people on either ends. So we call it as deviation from the mean. So you can have people with a low creatinine also, and you can have people with slightly high creatinine also. Whether I would call them as chronic kidney disease or not is very, very difficult, especially if they do not have protein in the urine and the creatinine is rock stable for years together. Then it is very difficult to label it. But technically, we'll have to take it as chronic kidney disease, and we give the same advice to them as to any other individual.
So I think we have come to the end of the questions. Over to you, Jay, for the closing comments.
I have two closing questions myself, Doctor. The first one is, we are all currently living in very strange times with the pandemic and all that. I know it's an unfair question to ask of you, but in the 1.5 years since we have had the pandemic, almost 2 years, have you seen anything that makes you curious in relation to kidney disease with respect to the pandemic?
Yeah, see, what was striking with COVID-19 infection was 40% of them developed some form of kidney disease. So be it protein leak or be it increase in creatinine. This is something that we have seen. We have biopsied people. We have seen various pathological lesions in the kidney. Very difficult for us to say whether it is directly related to COVID or not, but there has been a temporal correlation between an infection and then people developing protein leak kidney disease. This is one. The hitherto normal people developing some form of kidney disease, it's there in about 40%. And then we have problems in those who have already kidney disease, CKD. So these people, they tend to worsen. And many of them who had a very low creatinine, 2.5, stable for years together, just an infection pushed them into a stage where they needed dialysis. we are not able to get an answer to it. But yes, COVID, there is a very strong correlation between COVID infection and the kidneys.
So people who have been infected and recovered from COVID could still have possibilities in the sphere of kidneys. And so it is better that they get themselves periodically tested, is what
Yes.
you would say. Okay.
In fact, we go to an extreme of, say, for example, a donor for a kidney transplant develops COVID infection. We wait for 6 months before allowing him or her to donate the kidneys. We recheck the kidney functions, protein leak, everything in total after 6 months. And if it is normal, then only we allow them to donate kidneys. So,
okay.
I mean, that is the extent to which we are careful in terms of COVID and kidney.
Okay, but I suppose it's too early yet to get a firm understanding on why this correlation exists.
Yes.
Okay. My second question and my last question is more philosophical. We have heard you say many times that CKD is an irreversible condition, and the best way to guard ourselves is to do screening tests every so often. Okay. And in the test that we have talked about explicitly, one in relation to heart disease, which is basically blood pressure, which can be done by anyone at home, anytime. And the second one being blood sugar of any of those three types, A1C, random, and postprandial, sorry. Now, these can also be done at any time with the only proviso that A1C is a 3-month interval, correct?
Yes.
Now, at the same time, we often see, and one of your tables did talk about annual testing, and the insurance company, in fact, they recommend annual testing. My question to you is, if you are looking at frequent screening, and if these tests make it possible, at least to the level of 3-month intervals, shouldn't we have screening tests recommended many times a year, at least 4 times a year?
See, the screening...
Because we get more data points, and the data points will help you to understand it better as a doctor, right?
See, the reason why we say annual, in individuals who do not have any positive finding in their previous check, is that kidney disease takes years together to develop. It does not happen overnight. So that is the reason why we say annual checks in all these people, because diabetes effect on the organs is not a sudden process. It takes years to develop. Now, the frequency will come down if there is an abnormality that is identified. So that is the reason why we keep screening as an annual phenomena. And if we find something that is abnormal, then it is going to be much more frequent. It could be 6 months, it could be 3 months, it could be 4 months, depending upon the abnormality that we find in all those people.
Perfectly understood. I mean, and that is why I prefaced it by saying this is possibly a philosophical question, because from the point of view of nephrology or kidney disease, I understand what you're saying. Once a year, because it takes a long time for the kidneys to feel the effect. But for heart disease and for diabetes, more frequent screening of the order of many times a year can be more revealing, right? Not so much from nephrology perspective.
Yeah, in terms of blood pressure and blood sugar, I think it has to be monthly.
Monthly. Okay.
Yeah. So every time you check your sugar and show it to a doctor, I think it is mandatory to get a blood pressure examination at that point of time. And there is no shortcut to it. So you cannot say that I am a person who looks at only diabetes, I will not check blood pressure. That question does not arise at all.
Okay.
So it goes hand in hand.
Okay. Thank you so much, Doctor. It was a truly enjoyable and very informative session today. The way you laid it out, all the slides, very articulated and very clear to understand. So I hope all of the audience we have with us today got as much out of it as I did personally.
Yes.
In that sense, it has been a very enjoyable evening with you. And thank you so much for taking the time. We are at the time of the year when it's holiday season. It's Merry Christmas to everybody, and the New Year is coming. And one more version of the coronavirus is upon us. So on behalf of LBN Tech, on behalf of RedMed Systems, on behalf of NU Hospitals, on behalf of Dr. Padmanabhan, I would like to encourage all of you to keep safe and do your bit to understand yourselves in terms of doing the screening tests appropriate to your age, so that we are on top of all of these. Once again, Dr. Padmanabhan, very nice talking to you. And over to you, Megu.
Thank you.
Thank you, Doctor. There are lots of appreciative comments here, but I'd like to read out one from Mr. Sivasailam. Even bitter pills don't eliminate sweet miseries. Hence, management is the answer. I think he has summed it up beautifully. You have explained it well, he says, and there are lots of other appreciative comments too. So in this, I think it was power-packed. There are lots of takeaways for me too, especially the eye-opener where you say that low sugar, recurrent low sugar, and which heralds CKD. So, and infections also. And like that, there are several others. So thanks participants for tuning in, even though it's a festive Christmas occasion and you all have plans of going out. Thanks for tuning in from across the globe, and watch out for this recorded version in our YouTube channel. And again, last Saturday of next month, we'll be having an orthopedic or endocrinologist. We have still not got confirmation yet. So please tune in for that. All the details will come up to you. And have a lovely evening, all of you. Merry Christmas and a Happy New Year, all of you. Thank you.
Thank you.
Thank you, Megu. Thank you, Doctor. Thank you so much. Megu, there was one question. Whose limits keep changing? Is it based on country-wise or is it in general?
Oh, okay. I think it just came. Doctor, you have time, you can answer that.
Not an issue. I didn't get the question.
I think World Health Organization limits keeps changing. Is it because on country-wise or is it in general? Limits of what, Mr. Pati? You want to unmute and ask? You can. Go ahead.
No, the limits, they announce sometime something different. Is it based on the countries or is it in general they are coming out with those limits?
See, these limits are in general. They are not country specific. When it comes out from WHO or International Diabetes Federation, it is something that is for the whole world, and it is not limited to a particular country or a particular region also.
Thank you.
Thank you, Doctor.
Thank you, Doctor. Thank you. Thank you, all of you. Have a lovely evening and Happy New Year once again. Thank you.